Hi everyone, Larry Wynn, CEO of Summit Imaging, an ultrasound and mammography equipment support organization. And today is, really a video that is a bit of a different framework and different kind of content than, we typically do. And we wanted to bring on a couple of guests that, had on their own accord, wrote a white paper about counterfeit parts being used in transducers. And we have a couple of experts that actually did some testing, to demonstrate the degraded performance of this ultrasound equipment that's so critical to patient care. So we have.
Hi, I'm Carolyn Coffin. I'm a sonographer and an ultrasound educator, and I'm also an ergonomics consultant with Sound Ergonomics.
Hi, I'm Matthew Schwartz. I'm also a sonographer and an educator and a graduate student in physician assistant studies.
And just thank you so much for doing this. Number one, writing the white paper on your own accord to better understand the quality differences of correct ultrasound equipment versus incorrect ultrasound equipment, and then coming on to our video here to really share with the community and contribute on how to improve patient care. So really the intention here is how do we work together to improve patient care for the general population out there. And so let's just kind of dive right into it. You had asked us to come to our facility because Carolyn's been helping us with our image quality, QC, technical procedures. She's also been such a good friend and colleague to train every single one of our employees on image quality to make sure that the quality of the products that we send out are of the standard to be met for clinical use. And so let's just dive into what did you do in your experiment, and what did you kind of find out?
Well, we were curious about the impact of counterfeit parts in transducers. I have to say, as a sonographer in the clinical setting, I just relied on my equipment to be working and to be appropriately repaired, either by the original manufacturer or with original manufacturer parts. We, as the working sonographer, the end user, have no idea really what goes into the product we're using. We trust that it's met certain standards, and we trust that its quality is what we expect. We don't really know some of the finer details of the construction of a transducer. So through my relationship with Summit Imaging and meeting Larry and his crew, I've learned a lot of things about transducers that I wish I had known as a clinical sonographer, but that now I've started to question. And one of the things we wanted to do was look at a transducer that had been repaired with counterfeit parts and a transducer that had the original manufacturer parts. So Matthew and I put together just a really quick procedure where we looked at the resolution of structures within a test phantom and the resolution of the carotid artery in an actual subject, just to see if we could determine if there was a difference. So what did you think?
Well, some of our parameters that we made sure to control were turning off all of the image enhancement software
Post-processing.
processing packages, and just focused on the penetration and resolution of the pins, the embedded objects in the phantom. We noticed that the penetration between the transducers with counterfeit components versus the OEM components were relatively equal. But when we were looking at just the resolution between these embedded objects, there was a significant difference between the transducers with OEM components and the transducers with counterfeit components, in that the resolution was much greater. The objects were more clearly defined, crisper with the OEM transducers, whereas the resolution with the transducers that had counterfeit components in them, it was very clear. It was not clear compared to the original OEM.
So I think what we found out during that scan was that the clarity and the resolution of the counterfeit parts that have been installed by another facility somewhere else, we have no idea where, um, degraded the image quality to where there was a significant difference to where professionals like you could instantaneously tell by simply putting on a probe onto a phantom.
Mm-hmm.
And so that's kind of what we've been learning with Carolyn over the years, and now Matthew's a part of the team on really trying to tackle this issue to improve patient care. um, let's chat about the patient and what your thoughts are on, because of the degraded resolution. I think what's really interesting here, just to kind of throw into the conversation, is that the regulation right now for transducers is acoustic power, and there's actually a lot of information about that on the FDA website. Link down below if you are interested. But there's no regulation around the quality of the image, and so the acoustic power determines penetration. So we really weren't surprised that the penetration capability of these counterfeit crystals that we're talking about was very similar to that of the correct OEM crystals. But that's only a piece of the performance of a transducer. I think the critical piece that's missing here is the resolution.
Mm-hmm.
And looking at that phantom and then the carotid, and seeing that it's not as defined and it's not as clear. Talk to me about first patient care. Like, how does that impact them in your line of sight in the healthcare space? How does that degrade the care that we're able to give the patients by virtue of the equipment?
Well, I think that, first of all, the important thing to realize is that ultrasound is used for a lot of structures. It's used for a lot of body parts, and the use of ultrasound is growing significantly. And the variety of users is growing. So the users are depending more and more on their equipment coming to them ready to go and up to what they consider diagnostic quality standards. I think the issue is when you're looking at resolution, you're looking at not so much a large organ like the liver and the aorta and stuff that you can really see pretty well with anything. You're looking at the finer details of things that could impact the patient care. And what comes to my mind initially is looking at a small structure in the fetus, like the heart valves. When you're looking at an early fetus, doing certain anatomical markers for things like Down syndrome, you're looking for very tiny parts. You're looking for a small echogenic focus on one of the heart valve leaflets, for instance, or the chordae. You're looking at the very tiny bones in the fifth digit. You're looking at very small structures, and if they're not well resolved, you're missing or potentially misleading the interpreting physicians into a different path of decision making for the patient. Another point is that Matthew's brought up is the needle guidance.
Right.
Yeah, tell us more about that, because I thought that was incredibly interesting.
So ultrasound is a great tool for guiding needles for a variety of procedures, biopsies, aspirations. One of the more commonly used applications is IV starts.
Mm-hmm.
And typically when an IV is started, the beam is transecting the needle. So we're only getting a cross-section of the needle. Right.
Yeah.
So we're looking at just one fine
And what do you think the diameter of that needle is?
The diameter of the needle is, if we're talking
thousandths of an inch.
Yeah, 16 gauge needle. Yeah, just
18 gauge,
yeah, maybe
It's
half
small
a
enough
millimeter.
the needle is small enough to actually go into a blood vessel.
even smaller if you're doing nerve blocks.
And if you're doing nerve blocks, it's even
Right.
smaller. So
And
we're looking at
because
extraordinarily fine pitch equipment.
Yeah.
It is expected that your ultrasound equipment is going to be able to see that but see it clearly.
Right, right. You never want to be guessing where your needle is. You want to be able to see it clearly and accurately.
And often these procedures are being done and scanned by people who are not trained in ultrasound.
Right.
So the person holding the transducer is not a sonographer many times and has 100% reliance on the equipment
Mm-hmm.
having the resolution that he or she needs to see the needle tip.
Mm-hmm.
So you have an audience that of workers that really is incredibly reliant on the ethical construction of their equipment.
Mm-hmm.
But just to kind of put it in the context for the audience, what Matthew's describing is something that's actually more precise than threading a needle,
Yes.
because the tolerances are so tight. And now let's talk about if you had a fuzzy image, how much more difficult that procedure becomes if it was relative to a crystal clear image that OEM components would give you. So could you walk us through what those risks would be if you had just an image that was very difficult to work with, because it kind of informs some guesswork at that point to see where you're going.
Well, I think if we're talking about a needle guidance scenario, if the needle is not clearly seen, then a physician may opt for another modality to thread that needle, so to speak. These procedures can also be guided by CT, but that adds additional cost, additional radiation exposure to the patient, or depending on the emergency of the situation, a physician may decide to start the line blindly without ultrasound because the ultrasound is not providing the clarity that is required, which obviously adds a lot of risk.
Absolutely, absolutely. So as we talk about the patient, I think we just want to let's work through. We're talking about this from the the deployment and extension of healthcare technology to them. Let's talk about them. So what happens to them? So they come in for an ultrasound scan, and is there a risk of misdiagnosis or no diagnosis at all that with the proper equipment that should have taken place at that point of time?
Well, I think there's always the possibility of missing something, even with the best equipment. It's not a silo of equipment and a silo of the user. It's the whole picture. The user's familiarity with the modality, the quality of the equipment, and it all has to work together. Let's take the user and kind of put that person in one part of this discussion as assuming that they don't really know anything about their transducer quality. As we mentioned at the beginning of the video, they often just rely on the integrity of the company, both repairing it and the company that manufactures their equipment. So if we assume that they are expecting to have a piece of equipment that they can trust, then what happens while they're taking care? And also the patient is making that same assumption that the equipment is the best in the business and that the person performing their study has faith in that equipment. And if, in fact, you have a piece of equipment that isn't performing at the standard that you expect it to, the sad thing is that you could theoretically either completely miss something that would then go on to develop into a bigger pathology that would require more expensive treatment later, or you could misinterpret a structure or a finding that could lead the patient again into a path that they didn't need to be led into. So there's a lot of reliance on an accurate ultrasound image to make final treatment and management decisions. As I mentioned earlier with the fetus, there's decision making to be made about delivery methodology. If you have a pathology that might prevent a regular delivery versus a surgical delivery, you wouldn't want to put a patient through a surgical delivery that didn't need to happen. And the same thing is true if you have like kidney stones, for instance, and some of them are very tiny. Now, would they have an impact on the patient? Maybe not at the moment that you see them, But maybe later, if you've missed something, it could develop into a bigger problem, causing the patient an emergency room visit, things that could have been avoided um, with an accurate image. So I think at the peak of this, of course, is the patient care, and you don't want to miss anything. But also, we want to make sure that we educate the users to be skeptical, really, of their equipment and to question it. Because the patient really is relying on you as the user, as the sonographer or the physician. The patient's relying on them, kicking the tires.
Yeah, and we hear that a lot from our end user customers where we're working with sonographers like yourselves. It's because it's such an unknown issue that they would never know because when you get the transducers, everything's glued together, right? It looks pretty on the outside. Everything, the connectors screwed together, and you would never think to open it up because you would have no reason to. There's no assumptions there to do so. But what we're finding and what we're hearing from users is, boy, this image is really difficult to get. It's really difficult to get, and not really thinking about the resolution of the equipment, but they second guess themselves first when in reality it's the equipment. And so, work me through kind of what you would do if you had a fuzzy image, especially on some difficult studies. Like how would that increase your work time to get the image at that point? And then I think we talk a little bit about the ergonomics as well, to where, then you have, really the health of the sonographer themselves, to where they're really straining to get these images because it takes longer, but it's also more difficult because I have to imagine that you're just fighting this lack of resolution to get more data points to triangulate what you're trying to diagnose.
I think the important thing to think about is that ultrasound is being promoted by some of our professional organizations as being the first line of defense. So go to ultrasound first. Don't just automatically go to CT or to, X-ray or MRI. And more people are gravitating towards using ultrasound first. So if that is becoming the exam of choice, it has to be done well. It has to be reproducible. And if I can't reproduce the same image on a different piece of equipment, then which one is right? Which piece of equipment is right? So then you're stuck with deciding what happened and how do I justify that I saw this with this, but I didn't necessarily see it with this other transducer or this other piece of equipment. So it's a complicated issue as I see it, and I think that as I mentioned earlier, the user is relying on it to work. If you have a difficult exam, it could be a lot of things. It could be the transducer, it could be the ultrasound system itself, it could be the patient's size or patient's body habitus. And there's enough things in the body that react to sound or produce the image without you having to also worry about the transducer being as good as it can be. And from an ergonomic standpoint, which is something that is dear to my heart, is the longer it takes to get an image, whether it's the patient size or patient's body, or whether it's the transducer itself, the longer it takes to acquire the images you need for a full study, the longer you're holding the transducer and the longer you're being exposed to risk factors for musculoskeletal disorders and for injury. Not to mention the fact that it can be very frustrating if you can't clean your image up. There's a level of frustration that just takes over the exam for the sonographers, and that compounds injury, it compounds your relationship with your patient. So there's a whole lot involved in a bad image, more than just diagnosis. There's an entire relationship with the patient and the equipment that can be degraded and make for a very difficult workday.
Yeah. I think to Carolyn's point, ultrasound is an incredibly powerful diagnostic tool. And sonographers are in the business of gathering information and answering questions for the radiologists and for the ordering physicians in order to prepare and inform a treatment plan for the patient. And it's not uncommon that ultrasound is unable to answer a particular question. And as Carolyn mentioned, there are lots of different factors to why that might happen. And a report might read not seen or not well seen. And when ultrasound is unable to answer a diagnostic question, the patient is then moved forward in the diagnostic process of either being subjected to additional testing, which may offer more radiation exposure, CT/MR, X-ray, or could, as Carolyn mentioned, create a delay to treatment. That if the alternative is to wait a week and return for another scan or to have serial ultrasounds, every step that is added beyond that initial scan where the question
could have caught it with the correct equipment.
Right, exactly.
Yeah.
If it wasn't answered, that just adds more time and more cost, more stress to the patient in that path to find a diagnosis. And that has a ripple effect throughout the healthcare system. And obviously, if a sonographer is spending that kind of time to answer a question, knowing that the alternative is further studies, more radiation exposure, more delays towards a treatment plan, then a dedicated sonographer is going to push themselves to clean up that image and find that answer. And that puts a lot of strain on the sonographer themselves.
Yeah.
And it puts a lot of strain on department resources because in today's world, everybody's
It's not productive, right? I think that's really at the end of the day is that you want to help as many patients as you can.
And the departments are really pushing us and pushing the clinical sonographers to more throughput. From their perspective, it's productivity as part of their financial picture, and so either you just go faster and skip over things you can't see, or you really struggle with it. And I don't think either one of those is an answer. While we're talking about financial side of things, repeat exams. If you have to send the patient back for a repeat exam,
that also impacts the quality standards by the CMS. So
there's
actually isn't it like a 1.5% penalty on Medicare and Medicaid reimbursement? Yes, for repeat conditions.
Yeah, and so then you start to look at, Medicare is going to look very closely at why did you have to do 2 exams for this one pathology? And so, there's a whole lot of things wrapped around this one transducer. And productivity, patient care, sonographer safety, the financial picture of the institution is a huge piece of it. Another thing to consider is typically we don't think of ultrasound as a life-saving procedure, really, because we don't rush in an image right after a car accident, for instance. But there are exams that we do that do impact the patient in terms of potentially being life-threatening. And one of those is a vascular study for blood clot or deep vein thrombosis. And if the resolution, sometimes it's difficult, especially if it's a chronic situation versus an acute situation, it's difficult to tell those two apart. So if you don't have good resolution of a clot in the leg, the patient then potentially could go home, and that could end up traveling into the lungs, and then you've got a pulmonary embolism, you've got all kinds of serious, potentially life-threatening complications. So there's a lot to it that I don't think people have really, including sonographers, have really given significant thought to.
Yeah. So I think that's why we're doing this video, is because we wanted to contribute to healthcare by educating on these different optics and perspectives of healthcare. I mean, we see it from really an equipment support and supplier side, and you see it from the clinical side. And I think what's so fascinating about the conversations that we just have around the lunch table, and now formally bringing it here in front of a camera, is that there is a bridge that we need to build between the equipment side and the clinical side, because at the end of the day, to think of them as silos is a mistake,
Mm-hmm.
right? This is an ecosystem where there's an absolute dependency,
Hmm.
and we all depend on each other to provide the best patient care.
Mm-hmm.
And for us, we've been doing this for a very long time, and just so happy that we have the resources like this available to us to make sure that we can make a positive impact to patient care. And I think a question I wanted to ask was, we keep talking about not just the repeat scans of the ultrasound study, but talking about um, it unnecessarily moving to an MR or a CT. I mean, is that a geometric growth in healthcare costs at that point? Because ultrasound, I think we're relying on this technology because if you look at the imaging department, the cost basis of ultrasound is the least expensive, but it's becoming more capable. Therefore, a great way to lower healthcare costs is to actually lean on ultrasound more.
Mm-hmm.
And so, if we can't lean on it more because the equipment is degraded with counterfeit parts inside of them, then what does that cost structure look like for a healthcare facility and a patient if they actually have to move upstream to more intensive imaging? So, would we say that the cost would be of an ultrasound scan is far less than an MR or a CT scan?
The billing charge is less. Hospitals get more revenue when they order a CT or an MR.
Hmm.
Um, but in terms of the overall cost to the healthcare system, by ordering exams that are far more expensive, uh, it does contribute, I think, to the inflating overall costs of healthcare.
Mm-hmm.
I think the important thing is that the right test be used and the right test be ordered. Um, Sometimes it's, well, let's do an ultrasound first, and then if we don't see what we want to see, then we move on. So that kind of thinking has to come into it. And I'm not sure that's always the best for the patient. But certainly, if we are focusing on the quality of our equipment, then you would move on to a higher study if you don't have the
It would be
resolution.
absolutely necessary,
Yeah,
right?
if you
Mm-hmm.
don't have the resolution you need. So not only you're paying for an ultrasound, but you're paying for an MR
Yeah,
or
but I
CT.
think in for just a general population of health,
Yeah.
um, for who we serve, I think the message I was trying to convey is that it's better if we really lean on ultrasound to do the
Hmm.
initial diagnosis and reduce or increase the yield of diagnosis there with the right equipment, because then that sample or that percentage of patients that where counterfeit equipment could be used on them would continue to move upstream to the more aggressive imaging. In many cases, it's unavoidable that just ultrasound is the first gate, and then you would move on to something else. But that's kind of what we're trying to wrap our hands around, is those patients that didn't have to go upstream to the more
Right.
aggressive imaging. Even if it's just one,
Yeah.
right? Even if it's just one, the cost savings, the perceived savings of a counterfeit transducer is so myopic relative to even just one patient going through the entire imaging, suite, because the ultrasound didn't catch it when it should have.
A parallel comment to that is that as ultrasound is being used for more and more structures, the imaging has to give the physicians the confidence they need to make a decision. And so, for instance, if you look at musculoskeletal ultrasound, forever, shoulder imaging was X-ray or, some of the more expensive modalities, including arthrography, which is, injecting a dye and radiation exposure and all the risks that are associated with that. But it was the gold standard, and it was orthopedic physicians relied on. When ultrasound attempted to show them that you could easily image the shoulder and produce some of the same results, they were a little slow to be comfortable with that. So, if you want quality imaging with ultrasound so that you can apply it to new modalities with
Hmm.
confidence and get it accepted over the gold standard, you've got to have the resolution from the beginning, or you're going to lose your audience that you're trying to
Absolutely.
convince.
And I think that's the exciting part about ultrasound is that
Yeah,
because of the resolution, we're able to see so much more. Therefore, you can diagnose so much more without any invasive,
yeah.
scanning.
And that just gets better.
Yeah. So we kind of talked about the ballooning healthcare costs that are unnecessary. We can even add in equipment downtime. The frequency of failure of these counterfeit parts is much higher. So, when your equipment goes down, you just can't scan anymore, right? And so that's a bad business model for imaging departments. But number two, it's bad for the patients, especially because they need to be rescheduled. Right?
Mm-hmm.
They were expecting really some resolution from that scan that day, and they go, "Sorry, you can't come in. Please come in next week because that's when we can fit you in." That's such a costly phone call to make to a patient because that's patient care.
Hmm.
Um, so I think the final question I want to ask was, when you were doing the scans to build your white paper, what were your emotional reactions to the difference in resolution and then really kind of rewinding all the transducers that you've used? Um, Matthew, I think you had some really interesting insights into, what your assumptions were coming into it, and then leaving the experiment. You were just scratching on your notepad like
Hmm.
crazy. Tell us what you were going through and what you wanted to share with the community so others understand really the impacts of the equipment.
Well, like Carolyn mentioned, I have always assumed that the equipment
Mm-hmm.
I was provided to perform my job was at the highest quality, and that the manufacture as well as the repair of my equipment was regulated by the federal government. Um, and after looking at a number of the examples that you have showed us, uh, I feel like I look at transducers in a completely different way now. I had walked into my room, I had greeted my patient, I had put all my focus on my patient and the task at hand, never thinking about the validity of the equipment that I was using. And now when I pick up a transducer, I'm looking at it for different features, flaws in the structures, discoloration, and I've got this nagging thought now in the back of my head where I want to have more information about the equipment that I'm using. I want to speak with my department manager. I want to speak with the biomed department, medical engineering in the hospital to find out where was this transducer acquired? Was it purchased directly from the OEM? Has it ever been repaired? Has it been refurbished? Um, because, like I said, I always assumed that I knew that my equipment was
Mm-hmm.
top of the line and in perfect working order and had been purchased brand new. And there's a business aspect that as sonographers we are not involved in, but it is very clear now that it has a direct impact on patient care. And I believe that sonographers, anyone who uses an ultrasound system, needs to inform themselves about where their equipment came from and what hands it passed through on its way to yours. Um, because there are instances where counterfeit equipment and components can be used to repair a transducer or a machine that is sold as either new or used, refurbished, sometimes even certified, and in fact, that's not the case, and it has just completely opened my eyes to this new aspect that I need to continue informing myself on.
For me, it's like realizing that you're at the mercy of the repair facility as a sonographer, because you just don't know
The mercy of patient care and really the productivity
yeah,
as well.
yeah, the diagnostic quality. And as we're talking and as I'm thinking about educating ourselves and who uses transducers, I would like to make a division between the high-end users and the lower-end users. And by that I mean you've got large hospital conglomerates all over the country that can strike pretty good deals when they're purchasing their new equipment and can come up with um, maintenance agreements and stuff like that, and can work with companies and can do their due diligence on the repairs. But what also worries me is the smaller facilities. Like, let's say you have a small private office in a more rural community. What they're at the mercy of is
Who's willing to show up?
right and cost.
Yep.
So they're looking for an affordable piece of equipment, maybe on the secondhand market, and they're looking for the best deal they can get. And so what they don't realize is the best deal that they can get may be the worst deal that they're getting. Um, it's a buyer beware, and you get what you pay for. So if you want something that you can trust and that your patients deserve, you need to be informed at every level of the facilities. And I always worry about the smaller, more rural kinds of communities where they don't have access to this kind of vetting of their equipment, and they're really at the mercy of the cost. And yeah, it's going to drive the cost down, but
There's actually a higher total cost of ownership,
yeah,
right? And I think that's one thing that we've really
continued repairs.
been working with our healthcare networks that are all over North America, is that if you look at the counterfeit transducers and it's just awkward on how some of these things kind of go through, right? Over in China, they'll actually build a whole probe that looks identical to a transducer here, and then somebody just bolts on the connector that has an OEM serial number, and then they send it back out to the healthcare community for them to use it. We don't think that's right. We think that's wrong. It's there's a whole host of things. That's our other videos that we have on our channel, but it's kind of breaking down what you just said is buyer beware. It's the transaction may be a little bit less expensive, but it's going to cost you so much more. And we just started. This is just the first of many videos and white papers that you've told me that you're going to write. But this is just kind of a first episode, I would say, to begin the conversation on what are all the spokes that are impacted by this counterfeit piece of healthcare equipment. And by virtue of it being kind of the centerpiece, along with the people that are working with the equipment, that's really one object that impacts every single other dimension of healthcare. And we're going to talk more about how that's going to look, and diving deep into all of these broader topics that we spoke about today. But that total cost of ownership is that it may be cheaper today, but in 3 to 9 months it's going to be 4 times more expensive, because you may pay a little bit less today, but you actually bought it 3 times because it failed 3 times more than if you just bought the right thing or got the repaired right the first time and just lasted the entire way through. So I think what's really complicated about articulating these soft costs, I would say, is that it doesn't really show up directly in these financial statements that everybody's looking at.
Yeah.
And at the end of the day, it's going to percolate down to that. But at the same token, there's just so many moving parts because our healthcare systems are so complicated now, and it's easy to kind of get lost in the weeds. So, we're going to take it upon ourselves to really break down, all these soft costs in a bit more detail for you and better understand, you know, we already know that these soft costs are extraordinary relative to the minute cost savings of a transaction of a counterfeit transducer. Um, we need to continue to have those conversations to understand how large that problem is. So I think what we're going into today's conversation is that we know the costs are extraordinary for a one-time transaction savings. Uh, Now we're trying to figure out how extraordinary or how large that is. So the answer is obvious today. Now we're just going to try to codify it on, really how large is that ecosystem that's impacted. Well, I guess the $1 million question is, if you had a counterfeit probe or a probe that looked OEM with counterfeit parts inside, would you use it?
No.
No.
You heard it from the experts. So I just wanted to say thank you to both of you. Looking forward to your next, white paper on diving into some of the details. And, thank you, audience, for joining us on this webinar and on our YouTube channel. So again,
And I
Matthew.
would like to thank you for bringing this in front of sonographers and
Right.
starting the conversation to educate us, and having the strict ethical approach to this whole picture is admirable.
Well, thank you. We think it's our obligation. I mean, just by virtue of being in the business that we're in, of, ultrasound support, and a big portion of that is transducer repair. As we see this, we know it's wrong. And so the only way to help and improve patient care is to educate. And that's all we're trying to do. We just want to make patient care improve for the entire, population that we're serving as healthcare providers, right? And so, thank you for the kind words, but, our work is far from over. There's
Right.
still a lot left to do.
Yeah.
So thank you again for joining us. Link to the white paper is down below in the comments. So again, Larry Wynn at Summit Imaging.
Carolyn Coffin.
Matthew Schwartz.
And, like us on Facebook, follow us on LinkedIn, and thank you so much for joining us today. All right, bye.
Bye.